in my career personally. So let me introduce them to you. First of all, we have Dr. Det Ho, who is an alumna of University of the East. She also received her doctorate degree from Hokkaido in molecular biology and specialized in cancer research. So she continues to hold her practice here in Quezon City and teaches part-time in the Craniofacial Foundation of the Philippines. And today she is among the advisory board as well of Dental Access Media Publication. Ma'am Jet is also, if I would say, one of my mentors or my teachers in my undergrad and postgraduate, and I blame a lot of my success on her because she was the only one, and I'm pretty sure about this, who unlocked the potential I never realized. So she was one of those people who saw that and believed in that. So thank you for that, ma'am. And also, the second member of our panelist, a very good friend of mine, my classmate since 2005, no, Dr. Archie, because 2003, I think. Yeah, I think all the way. Kind of, because I got delayed. But Dr. RJ was one of the top people in our class, consistent Dean's Lister, and with multiple awards from his studies. So Dr. RJ is also an alumnus of University of the East, and he has been bestowed as well with the Gloria Macapagal Arroyo Most Outstanding Graduate Award. And he was consistent as the Dean's Lister on the same university from 2003 to 2009. In fact, you were a scholar, right? Yeah. So he completed his exams in the General Dental Council of United Kingdom. So he's actually a registered dentist over there in 2015, since 2015, and currently holds a position as training officer dentist at the East Avenue Medical Center. So Dr. RJ also is he's the program head for our surgery course that we have, that we usually run. Right now we're on our second batch, and we're going to go to our third batch. And Dr. RJ has been specializing here on surgery. He got his training as well from PGH, and he's a highly technical digital surgeon, as I would call him. His approaches are very different, but the reason why we have him this morning is because we would like to rely on his expertise, because he's actually a frontliner who is working in East Avenue, as I mentioned. And right now, he's, unlike most of us, he's accepting a lot of patients in his care. And also, basically, he's already in the fire, as we would say. So I think there's no better person to ask than someone who is already in the battle. Right. So with no further ado, we would like to go straight into this. So we have 3 parts here. We want to know a little bit more about COVID, the last news or the last evidences that we have on COVID. And also the second part is how are we going to handle this quarantine phase, and also the post-quarantine phase, what are we going to deal with after. So right now we have about 120 people live watching with us. So we would like to say hi, most especially to the Filipinos, and also those coming from different countries. And for those who are going to watch this on replay. So without further ado, are we ready? I suppose we are. Okay, so Ma'am Jet, take it away. Our first question is, what is it exactly that we are dealing with right now? Who is this COVID-19? Where did it come from? Where is it right now? How are we going to go about this as far as the technical aspects of this virus is, and how it relates to our human bodies?
Okay. First of all, like all viruses, the thing with COVID is that right now the research is ongoing in a lot of countries. In fact, I think there is no laboratory in the world that isn't dedicated to the COVID. The thing about this is it's because it's a virus, it's not so simple to address. Not like your typical bacteria or your fungi, wherein you immediately have medications for this, like your antibiotics or your antifungal. Although some viral infections do have, for example, your immunoglobulins, which you can actually administer to the patient to address the viral infection. For COVID, it's not quite the case. As like all other viruses, you have specific mechanisms. But the main mechanism here is that the genetic material, whether it's the DNA or the RNA that's injected into the host, usually what the virus does is that it introduces its own genetic material to the host cells, meaning to the patient. And in doing so, it introduces now a change in the mechanism of the patient's proteins. So what happens is that clinically, that's the result, the patient gets sick. As to what the specific target is, right now, there's a lot going on. Of course, you have the lungs, but then again, there are researches showing that it's not particularly the alveolus or the lungs, but rather the blood vessels and so on. So it's really quite complex at this point. There is no definite study coming out. All they know is that when the virus enters the body, it introduces its RNA into the host cell or the victim or the patient's own cells. And then after that, it introduces a whole new set of DNA, which actually meddles with the functions of the body. And then you have now the cough and so on, the typical, flu symptoms and signs. So in doing so, there are now different studies which show that, in fact, the original virus may have mutated. So there are now actually two strains. There is a stronger strain, according to one study, rather than the other one. According to some studies, they showed that the ones that have infected people in Europe, for example, is the stronger strain than those who are infected in Asia. Nevertheless, despite the difference in virility or strength, it's still highly infectious. Initially, it was thought to be just an ordinary flu virus, but now it's turning out to be more infectious than your ordinary flu virus, and it's even becoming worse than your ordinary flu season. So with that, with knowing that it's highly infectious, of course, you have to take special precautions. Other than that, it's also been shown that, well, there are studies, and this is specific for, I think this would interest a lot of dentists. There is a study that has been shown that the virus actually can reside in salivary glands. Okay? And in doing so, usually this kind of behavior of the virus is usually shown in, or is usually seen in a symptomatic patient. So when we say that the patient is asymptomatic, he doesn't show any clinical signs of infection. But then again, he is a carrier of the virus, and it resides in the salivary gland. So if we recall our pathology, wherein you have, for example, your chickenpox virus, which remains in a latent state until such a time when your immune system gets toyed around with. It's pretty much the same with the coronavirus. It can stay in a latent stage. It can be still infectious, despite the fact that it just resides in the salivary glands. And as we all know, in the dental practice, we have a lot of exposure to this, and that can be worrisome for a lot of dentists who are planning to go back into practice. There's also the thing that the COVID actually inhibits or starts to enter the human body or the patient, and will actually show signs and symptoms 2 weeks after infection. So you have that stage wherein you're actually not showing any signs and symptoms, but are already infected with the virus. So within that 2-week period, that patient is also considered to be infectious. So these are some of the things that have to be taken note of when it comes to the coronavirus. And these are the latest studies that have been going on. And another study, which has been released just around 3-4 days ago, is that one of the mechanisms of the coronavirus is it actually can affect the performance of the T cells, similar to what happens in your HIV infections, for example. So it dampens the T cells. So that's a problem with their immune response, because if you infect the T cells, or if you change the way the T cells behave, then you expect a lower response from the body, from the immune system. And I'd also like to address the fact that, well, there have been, of course, data coming out that, of course, there are high-risk patients, those who have comorbidities, those who are more aged, but there also have been deaths caused by the coronavirus in younger patients, for example. And the reason behind this is they've seen in another study that there is such a thing as a cytokine storm, wherein you have an overreaction of the immune system. And in having that overreaction, what happens is that the normal function or the normal organs are also affected by the over-response of the immune system. So these are the things that we have to consider when it comes to the coronavirus. It's a relatively new virus. The behavior is still continuously being researched on. So we don't have anything that definite, especially when it comes to the clinical setting in dentistry. There aren't any studies right now when it comes to dental practice, how much a dentist can be affected by it, how much you can cause cross-contamination within your patient pool. So these are the things that we have to consider when it comes to reopening our clinical practice, even post-ECQ.
Okay. So it's very interesting. I got kind of nervous when you said that part. Do you remember in your pathology? Yeah, but I think some of us would have this.
Yeah. Well, you have to remember pathology. Yeah.
You were my professor in oral class too, so I'm not taking that well because I don't think I can remember anything. But
yes.
I think some of us would have this question, and I also had this question at one point. How exactly, not exactly, but how does COVID relate or compare? How does COVID compare to HIV or AIDS virus? Okay, so I think ma'am got some technical difficulties. Oh, you're back. All right, great.
Yes.
Okay. Yeah, so my question was, how does COVID compare to HIV or AIDS?
One study that they found now is that in similarity to your HIV, wherein your T cells are directly affected by the COVID, I think around 2 days ago, they found out that there might be a similar mechanism when it comes to the COVID, wherein the COVID can actually interfere with the function of their T cells. So again, if we go back to your pathology or your immunology, one of the important cells in the body which can actually battle or go against a viral infection is the T cell. Unfortunately, for HIV, and now they're seeing it in COVID as well, even the normal T cell function and T cell count even is affected by your COVID. In fact, since this virus is so strong, and since the infection can last for a long time, what they found out is that the T cell count goes lower as the infection progresses, or as it gets prolonged, the T cell counts go lower. And that's a cause for worry, because if you have abnormally functioning T cells, then you lose a part of your immune system which can actually perform or battle against viral infection. So if you're in effect, you're saying the immune system gets weakened in the process, and that's a cause for worry, of course. So that's what happens, or that's what they see happens with the patient infected with the COVID.
So it's the response of the body where it becomes kind of similar on that end.
Yes, it's the response of the body. What they see is either you have a weakened immune system, or we're very healthy individuals, and we've taken note of the fact that there are cases wherein you have totally healthy young individuals who have been infected by the virus and who ended up dying. And what they figured out was this, what we call as the cytokine storm. Cytokines are biochemicals in the body which can lead to inflammation. And the thing is, if you have an overreaction of the body, you have all these cytokines being bombarding the body, causing a lot of inflammation in the process, affecting a lot of organs, and eventually even probably death. So there's no assurance that only sick individuals or old individuals or people with comorbidities are the ones infected by COVID. Anyone can be infected by this, young or old, healthy or not. It really depends on the body's immune system reaction. You have T cell counts which can go low, or you already have immunocompromised patients who are of course at higher risk. But then again, you have healthy individuals. So if a patient walks in and he says he's healthy, he's not showing any sign and symptoms, either one, he can still be an asymptomatic carrier, which is there are around 30% of COVID infected patients who are asymptomatic. Or two, he's already been infected and you're just waiting for that 2-week period where clinical symptoms will actually come out. So there's really no an assurance at this point unless the person has undergone testing. But then again, if you're going to talk about testing, because the testing is done either through PCR, which is the gold standard, of course, because with the PCR test, you actually check the DNA sequencing of the virus or of the sample and compare it to the DNA sequencing, which has already been verified and submitted to a scientific body, and to confirm the presence of that virus in your body. You have antibody testing, which is what otherwise is known now as your rapid testing, which of course you can still use, but is of course less reliable because with the rapid testing, you wait for antibodies to be produced, and that can come after a number of days after infection, because you don't immediately produce antibodies 5 or 10 minutes after being infected by the virus. So of course, this can lead to false negatives. But then again, until we have such definite proof that the patient is definitely not infected, and there's really no assurance at this point. The country yet has to undergo mass testing, so we're really not sure of the numbers right now. Even if the recovery rate is high, we aren't really sure of the infection rate. So there's a lot. I think in order to plan whether or not it's safe to open a dental practice and go back to how life was prior to COVID, I think it really depends on how bad the situation is in the country right now.
A very interesting point, and what you said that anybody would be a candidate, anybody could be a candidate, and it doesn't matter how healthy you are as an individual. And I think what really matters right now is, number one, social distancing in the sense of staying inside your house. So wala nang makulit.
Yes.
So how
and
exactly
when it comes to social distancing, yun na nga,
yeah, go ahead, ma'am.
I mean, when it comes to social distancing in the dental practice, I mean, definitely that's one thing we cannot practice when we do clinical work. I mean, social distancing is not possible when it comes to the dental practice. We all know that. So.
Yeah. So like I said yesterday, let me just go back to my practice, to not practice. So just a question, another question is, how exactly does this virus go around? Is it airborne? Is it in aerosols? Should I be worried about the air that I breathe? Should I be worried about the surfaces that I touch? Should I worry about the people who come into my house or near my house? Should I be worried about my neighborhood?
Okay, like all viruses, I'm sure there's such a thing as air. It is definitely airborne, and there are already studies which have shown that it is indeed airborne. But the chances of being infected after it being airborne, especially in an open space, it's quite low as compared to an enclosed space where you have all these viruses floating around. But more importantly, and I'd like to emphasize on this, is that what's more infectious is the part where you have direct contact. It can stay in a surface. They say that in metal surfaces, it survives less than in plastic surfaces. So if a patient enters your clinic, it really doesn't matter if he walks in and he stays in your clinic. I think what's more scary for us as practitioners is the fact that we have to handle this patient. We have to get into the oral cavity, practically touch his saliva and every other component which is directly in communication with the patient's respiratory tract. which we all know will harbor the virus. And in doing so, I think that the chances of getting infected as a practitioner would be higher because one, we have to work from a space which is less than 2 feet, okay? And the requirement for social distancing is at least 3 feet. Sometimes we have to work at the point when we're actually face to face with the patient. Number two, we have instruments which enter the oral cavity. At this point, again, I would like to reiterate on the fact that there aren't really any studies right now on a dental clinic setup because, like, right now I'm here. I'm stuck in Canada, and I can tell you that the infection rate here, where I am staying right now, is only at 1 to 2%. So that's very, very low. But the government has emphasized that at this point, they don't want any of the dental clinics to open unless it's a dental emergency, and in which case, all the dental clinics have posted their phone numbers for initial consult. And then after doing that, that's the only time they open up their practices. But definitely any other form of dental work at this time is not allowed. And this is at a 1 to 2% infection rate. So this is quite low compared to what we have in the country. And the government is being very cautious about this because it's not only us being frontliners, it's also the chance of passing on the virus from one patient to another because one, how do we assure the sterility of our equipment and our instruments unless everything is 100% disposable? Because I think that's the only way you can assure yourself that the virus will not stay on the surface that it was introduced to. So you can imagine that if you have a COVID positive patient, the very chair, the dental chair where he sits, the saliva ejector tubing, okay, which can of course have some flowback, the spittoon, everything will practically have a chance, you'll have a chance to harbor that virus in the clinical setup, regardless of whether or not it's aerosol. So it's not even it being airborne that's worrisome. It's just it being present in anything that it gets into contact with.
Yeah.
Plus the fact that, of course, we're working on an area which is actually the entrance of the respiratory tract. And again, you have the salivary gland, which is a very good place for the virus to get harbored in, according to one study.
Okay. It's very interesting, but it's also very worrying as to how we're going to go about our normal lives. So I have a question. Are there any data on how these types of viruses would be eradicated in a sense that, like, when do you think this would end? Some news centers, they say that it's going to be up until 2022, 2025. Is that realistic?
I'll be very realistic. I think this is a virus that will stay on. I mean, this will be like your typical flu. I don't think that we can get it 100% totally eradicated, but at least at some point it should be controlled. There is such a thing as flattening the curve, but flattening the curve doesn't mean that the situation has been resolved. Flattening the curve means that you've slowed down the reinfection or the infection to a rate wherein the medical system can actually accommodate patients. Because what is worrisome about the coronavirus right now, or the COVID, is that the infection rate is so high, just like and we're scared that at some point we might end up like New York or Italy or Spain, wherein the medical system completely bogged down because the hospitals, the health workers, none of them could be accommodated anymore because of the rate of death and of infection and so on. So when we say we're flattening the curve, it simply means that we're buying ourselves time until a vaccine probably has been developed or a cure has been developed for that matter. There are drugs under experiment right now, under clinical trials. One is hydrochloroquine plus AZT or zithromycin plus I forgot the other one, but it's a chemotherapy drug by Roche, and they're trying on a cocktail of that. So far they've had a 70% success rate, but it's not a clinically controlled study, so they're still doubtful about that. There is another one out in the market which is also being tested. So far good response according to the trials, but we're still waiting for definite results. So right now, everything's floating in the air. Vaccines, they are on the work for certain vaccines under clinical trial, but there was one research in India, which in cooperation with the UK, which is still to be verified, but according to the Indian study, all previous researches on the specific COVID vaccine can be thrown out the window because there is one particular protein on the viral envelope of the COVID, which interferes with how the vaccine is actually supposed to work. Because as we all know, vaccines work through protein-protein interactions. And if you have a problem with a certain protein in the viral envelope or the thing which covers the virus, then it can disrupt the action of the vaccine. So at this point, every solution is floating in the air. So there is definitely no way to say that, we're near a solution when it comes to the COVID. That's why everything is, just stay in precaution. And I think once mass testing gets underway, we'll have a better picture of how the situation is in the country, and then we can make decisions. But until then, I don't know. I'm pretty much in doubt. We don't even know if we have that much infections. Maybe we've been spared. We really don't know at this point. But what we're trying to avoid adding to the problem by causing more infection or being a source of infection. And we're trying to avoid a scenario where, our hospital system won't be able to handle anything anymore. So that's more worrisome in my opinion. So I think what people think is that when they say we've flattened the curve, we've actually eliminated the virus. No, I don't think so. There is no solution to it right now. And in fact, with the virus, there are already cases of reinfection. So it seems that the virus is not creating any form of memory. Okay, not like your chicken pox or your mumps, wherein you have memory cells being formed post-infection. In the case of the COVID, it doesn't seem so. So you can forget about herd immunity as well, because you cannot have herd immunity if your body doesn't have the capacity to respond by creating memory cells. So even that can be thrown out of the window.
Okay. Ma'am, would you say that would there be any virus in the past that would compare to the aggression of this COVID that was handled in history?
No. Maybe the plague, I don't know. But I from what I'm seeing, as far as someone who's done research, I think this virus is very puzzling. It is exhibiting characteristics that have never been seen in the past. I mean, there are a lot of presumptions that have been made and have been disproven because, it just doesn't follow the standard viral pattern. It introduces reinfections where it's not supposed to. It has now 2 strains, so we're not even sure of how fast it mutates. Hopefully what I'm thinking of is that this virus has been here for a long time. It's just that it's probably mutated, and it's probably because of the situation in Wuhan, this virus has finally been given attention to, and now we're seeing infection all over the world, and probably it's been here on a regular flu season. It's just gotten worse. We really have no idea, and people are still trying to trace it. There were theories that it's been lab reproduced, but studies so far haven't been proving that. Studies have been showing that it's a novel virus, so that means that it's pretty new. The sequencing has never been discovered. It's only been discovered now. So there's still a lot of work to be done on this particular virus.
This is we're getting worried and worried all the more. So it's really what do you feel about that? Do you think this is a engineered kind of virus, or do you think this is just really a force of nature kind of thing? I mean, It's a very controversial answer, ma'am. So be very careful.
I don't think. Oh yeah, I know. There have been theories that it's been reproduced in the lab. It's been used for an experiment. There are theories about that, but I've been seeing studies from different scientists which have disproven that. So I don't think it's the case.
Yeah.
I think that it's like all viruses. It's been there, but probably through time it has mutated, as has been shown. There are already 2 variants, and in one study I even read that there might even be 8. So 8 variants of this particular strain. So
Yeah.
just like any flu virus, I think it's just because it wasn't, people didn't take it seriously. I mean, even I didn't take it seriously at first. Because of the data that initially came out from China, I used to think that it was just a simple flu, because even the flu can cause this much death and this much problems. I mean, these much problems, so much reinfection and so on. I mean, there have been thousands of deaths in a regular flu season. 3 years ago in the Philippines, we've had 20,000 deaths caused by the regular flu. So in my opinion, initially, I was thinking this was just a regular thing. But when the data started coming out and when the infection rate started to show, then of course my opinions have changed. Now this isn't a regular thing, and researchers are starting to pour in, and people are questioning the protein sequences, how the virus gets inserted, how a vaccine cannot be easily discovered, and so on. So there are a lot of problems when it comes to this virus. So it is relatively new. It's puzzling a lot of scientists, and I don't think there's any research lab right now that isn't concentrating on this. I mean, if there's one thing that it's done, it's united all researchers from all over the world, and just put focus on this.
Yeah, very interesting on the nature of this virus, that it's consistently changing. It's changing at a rapid pace. There's a lot of new things that are coming out, and it seems like there's just really not enough evidence for us to basically, I mean, to put it in a practical sense, there's not enough evidence as of now in order for us to rush back into the practice after, let's say here in the Philippines, it's going to be our lockdown will end in about 2 weeks or so. I think this should be enough testament to us that we should not rush into the practice immediately, because the evidences, although there are a lot, they are still ever changing.
Yeah, in my opinion, as long as we don't have a clear picture of just how bad the situation is there. So as long as mass testing hasn't been performed in at least 60% of the population, and we're not talking of just Manila, I mean, we're talking of the whole country, talking about the whole country. I don't think there can be anything definite at this point. I mean, if this isn't your regular, our practice is special in the sense that, direct contact is a must with patients. That's what I'd like to emphasize. I mean, for those in the forefront, for those in the emergency rooms doing testing, yes, they do encounter patients. They do have to treat them. But you have to remember that how a doctor treats a COVID patient isn't the same way we treat a dental patient. Doctors will come face to face with them and will get exposure times of what? I mean, 20 minutes. Whereas for us, we have procedures which last for 1 hour, 1 hour 30, or even more. And if this were a COVID positive patient, plus the distance that we have to perform this procedure with, I mean, this is a deadly combination. You have hours in front of a patient who may be COVID positive, and you have a distance of less than 3 feet. You have direct contact via your instruments. You have direct contact via your equipment, and even the PPE, and even if you have, say, the PPE and so on. I mean, I don't know. I'm kind of fearful of that. If you're planning to go on full force regular practice, in my opinion, at least, I really have doubts.
All right.
As to infection, and I would still limit.
Okay. By the way, to the public, we are live right now, and Dr. RJ and myself, we're live from the Philippines, and Dr. Jet is live from Canada, from Vancouver, if I'm not mistaken. But you guys can ask any question, and you can write it down here in the comment section. And if you we would try to answer everybody right after all that we discussed. So just a final question about the characteristic of this virus. I think around the first quarter of the news that broke out, we had a transmission rate of about 1 person could transmit to 3 persons. So far here in the Philippines, the rate is at at the start of the curve, so to say, or at the start of when they counted or they did testing. They said that it's 1 is to 1.6, and then right now they're claiming that the curve is flattening to I think it was 0.4 if I read it correctly, if I remember it correctly last night. So does this promise any bright future for us in a sense that the rate of transmission is slowing down, or is this just a transient thing that could blow up anytime?
Okay, one thing, if you read the news this morning in Hokkaido, for example, they're now experiencing, and in Singapore, they're now experiencing a second wave of infection. They've already flattened the curve. In Hokkaido, for example, in Japan, now they're under a state of emergency because they had a zero infection rate for quite some time. And now they're experiencing a sudden rise in the infection rate, and none of this has been introduced from outside the territory in Japan. These are all local transmission. So that is one cause for worry. So it doesn't mean that if you flatten the curve that you eliminate the chance of infection. In fact, there can be a second wave of infection. That's one point I'd like to stress. The second thing is I'd like to know how the infection rate was computed, because without mass testing, you're just basing the infection rate on those who have exhibited clinical symptoms. But then again, 30 to 40% of those infected with COVID can actually be asymptomatic. It doesn't mean that if they're asymptomatic, they cannot be carriers, nor does it mean that they cannot infect other people. They still can. So my question now, and there are those who exhibit mild symptoms, and I think the testing that's being done there, if I'm basing it on the news at least that I've read, is being done on people who have been exhibiting severe symptoms. So at this point, I'd like to ask, where was this based on? The flattening of the curve, was this based on people exhibiting severe symptoms? And I'm sure that
based on testing hasn't reached the province.
Exactly. And has the testing been done in people in the provinces, for example, or are we just concentrating on Manila? And in what parts of Manila are we talking about? In terms of the death rate, how did they attribute the death rate to those infected only with COVID? I mean, with, for example, those who died of pneumonia, for example, has this been attributed to COVID, or automatically has the death rate been computed on, people who have been initially diagnosed with COVID and who died? Because there may have been those who have not been tested and who have actually been infected and who died. So at this point, again, I'd like to reiterate on the fact that testing is important if we want to come up with good numbers and how to handle the situation. Because if we underreport this, we definitely cannot come up with a solution, and we'll be working on a false premise. So that's more of my worry over there. I don't know how it is. I haven't been there for quite some time, so I really don't know what's going on. But if I'm reading the news correctly, mass testing hasn't been done yet, and so I'm really doubtful of the numbers at this
point. Okay, so from a public standpoint, mass testing is really needed. More evidence should be found. More evidence should be reviewed, as it's ever changing every day, as you both said. Twitter is actually on fire in terms of COVID and how it's updating the public. So it's more faster than Facebook, more faster than news outlets. And basically, Twitter is right out of the hands of the scientists. So that's very that's going to be very helpful in basically informing us. In one of the infographics that I sent, that I posted on the bio page, the very first infographic that we posted there was, you have to inform yourself sufficiently. And I think right now with what Ma'am Jet, Dr. Jet said or mentioned, I think for us dentists who are practicing, it's very important for us to inform ourselves before we even think about protecting ourselves. We have to inform ourselves of who this virus is, who our enemy really is. Because we have only, I mean, the saying goes that you only live once, and if you want it to be your last, then we have to be very careful. And I think we can't fight this with brute, but we really have to fight this with a lot of knowledge, a lot of wisdom. The evidences are ever changing. We must constantly update ourselves. Mass testing is a must for the public, since our patients are the public. The numbers that are being presented as far as what we have here in the Philippines is not reflective of what is really going on. I'm pretty sure there are a lot of asymptomatic people. I'm pretty sure there's a lot of people who are experiencing, who have this COVID virus, but they just don't know because there's no symptoms. I don't think, anybody in their right mind would go for testing without feeling anything. So I think those who have felt something, that's the only people who went in. There are some news as well that I've heard. Well, this is outside, but it's from inside. It's actually inside information from some government friends that it's not people don't get tested as fast. This was information in the old days. Per se, maybe around 3 weeks ago, that a PUI or a PUM does not necessarily merit you a chance to get the testing done. So you really have to exhibit bad symptoms. That's why there's a lot of people who get diagnosed when they're already dead, when they're already burned, which is a very unfortunate thing. And it's a very passive approach as well, all in all, as from the government standpoint. So,
I just like to add, because I'm sorry, just one thing. I'd like to give Korea as a standard, okay, for how they could normalize everything, because massive testing was done there. And I've heard that it's been like drive-through testing and so on. So if that were the scenario back home, yes, of course we could say that, life can go back. And even with that, they still had reinfection and they still were pretty cautious about social distancing, even with that. But according to one former student, one of your batchmates, who has connections there, even dental clinics they do normal work, but they're still pretty cautious, because what they do there is they have actual testing in the dental clinic before they treat any patient. So that's the scenario there. So unless we can come up with that scenario, I don't think we can say that 100%, life can go back to normal.
Okay. Very interesting. Thank you, Jet. We will have you still inserting in a few other points that we're going on to the next. So we're going on to our next part, our second of three parts. So this quarantine, and right now we have Dr. RJ Dulay, who, as I said right at the start, is a frontliner. He's treating patients right now in East Ave from Monday to Friday on an emergency case basis only. So he's already in that battle. He's already fighting within this pandemic, and I think there's nobody else who we can ask better than himself. So, Dr. RJ, if you can just give us a little bit of a background, who are the patients that you're handling right now? What's the nature of acceptance of patients that you're doing in the hospital? Dr. RJ, you have to unmute you first.
Okay.
All right.
Can you hear me?
Yes.
Okay. Ang serious nung usapan, no? I just wanna put it on on a very casual note. I think what's the takeaway from what Ma'am Jet discussed is that we should be worried. Yun yung I think na kailangan nating maintindihan, that this thing is something we still don't know everything about. So parang ang hirap kasing mag-prepare when you have an enemy that you can't see and you don't know anything about. But with your question, right now, we're treating the same market of people. So since we are a government hospital, most of our patients coming in are the indigent people pa rin. So it's not different from what we were used to seeing. I think just because most of dental private clinics are closed, we are getting a lot more patients coming in from different classes right now. But yun na nga, since we are very keen on keeping the treatment to emergency cases, hindi rin kami tumatanggap ng walk-ins. I think I've posted a parang post in Facebook, in social media, letting people know that they have to call prior to coming in so that matatriage namin sila beforehand, and then we can tell them or advise them whether we can treat them at the clinic or not. So there's no change.
I think so I think our command center will post that in a very short while. The review or the checking out our patients before, it's teledentistry, right?
Yes. Right
Something
now,
like that.
Right now, kasi we want is minimum exposure, both for the dentist and for the patient. So if you do teledentistry, somehow you minimize that exposure risk. Pag na-consult mo na yung patient through phone, somehow you get the diagnosis and you give them sort of a plan or a treatment that they can do at home. And then once the condition is stabilized, then we can let them know now, probably you can come back, and then we can do the stuff that you need to be done with. So,
all right. So what you're saying is that the very first step is that they have to send a message and then review them, screen them through teledentistry. Basically, the triage starts right there.
Well,
right?
I think it's different. It's different per clinic setup, because in our practice, since hospital-based kami, we get more walk-in patients than those who would call, even way before COVID. So, ang hirap din kasi with the market that we serve, nasasabihin namin sa kanila, you have to call. Normally, we get more walk-ins. So with that, we've set up our own triage in the hospital. So for all patients coming in, they have to go through a triage wherein meron silang sasagutan na questionnaires. For example, travel history, or are they experiencing COVID symptoms and whatnot. And then after the questionnaire, they'll be checked by a health professional. Kukuhanan sila ng temperature, and then if they have questions doon sa questionnaire na sinagutan nila, doon lang sila mabibigyan ng sort of pass. So the pass will allow them to come inside the building or the hospital. And then doon lang sila makakapunta sa clinic itself. So you go away with seeing patients na may symptoms, and then pag walang symptoms, doon sila makakapasok. I think what's important right now, especially if the quarantine is lifted, is yun na nga, to set up a telecon or a teledentistry in a way that makakaroon ka ng opportunity to weed out patients before they come in. Yun na nga, to minimize exposure risks for both parties.
All right. First of all, Dr. RJ, there are some guests who are coming from an international standpoint, so we'd like to maintain some English. That's something that's okay. And then next is that, all right, very interesting point that you said. Just a question, in what do you suggest in our own practice? Like, for example, we have it in a commercial place, or let's say in the mall. Would you suggest that, okay, the first layer would be through teledentistry? We can put up a sign for those who are planning to walk in to text this number first, and then contact them through message. And then the second part, do you think we should have another tent or another table outside of our clinic to screen them before we actually get them in? Or we do all of this? Do you think it's a smart thing to just bring them in?
I think that's the most ideal thing that all practices should do. lalo na if yun na nga, the goal is to minimize exposure. If you do call before the consult, yun na nga, you get to diagnose the patient, you get to know what treatment the patient needs. Therefore, you plan out whether this procedure will require you to do an aerosol generating procedure or not. So dun pa lang, from that time, you kind of get the idea, do I need to schedule this on a later time of the day or the earliest time of the day? So it sorts of gives us the isolation thing, diba? Self-isolation or distancing from other patients. Secondly, if they call before and then you don't do triage in the clinic, what's worrying is some symptoms would appear 2 or 3 days after calling, diba? So if their symptoms come up pero hindi ka na nagta-triage in front of the clinic, you kind of miss out the people who've developed symptoms after calling for the consult or after calling for an appointment. So I think calling and triaging is 2 layers of protection already.
Yeah.
So I think that's the most ideal thing to do.
That's the first layer of your PPE.
Yeah.
All right. So it's interesting on how you screen your patients on these 2 layers immediately, even before doing maybe a third screening. Do you have a third screening when they sit down on your chair?
Third screening, probably when you do the
Like
oral
you yourself?
exam.
Yeah.
When you do the oral exam, because sometimes there've been studies showing that when a patient is COVID positive, the tonsils are inflamed or there's some swelling around the area of the oropharynx. I think that's the third layer of examination that they can use. But I think it's more than enough to do the calls and then the triage prior to coming into the clinic.
Okay, so I think it's very easy to screen somebody who is symptomatic or somebody who experienced symptoms or somebody who has a history of COVID. How difficult is it in terms of how do we go about patients who are asymptomatic, who don't even know that they have or they're carrying COVID? How do we screen those patients? Is there any chance that we screen them? Is being a PUM or PUI enough or something like that?
Actually, that's the challenge right now, because studies coming up show that 30 to up to 40 to up to 50% of all positive coronavirus cases are asymptomatic. And that, in fact, is something it's difficult to say just by seeing the patient. So I think testing is the only way to determine whether a patient is or not positive to COVID. But until you do testing, you're basically unaware kung positive siya o hindi. So at the clinic, at the hospital, unfortunately, we consider everyone as PUIs. I think if you consider everyone as PUI, you sort of prepare your mind that I might get infected if I don't do PPEs, if I don't put 2 or 3 layers of protection when I'm treating this patient. So in my mind, we're prepared na if we treat this patient, this is a possible PUI or this is a PUI already.
All right. So basically what you're saying is that you're treating everybody as somebody who may have COVID, regardless if you're exhibiting none or you're not in contact with anyone. You just have that mentality that everybody is contaminated. All right. So with that said, does it make sense? So with AGPs or aerosol generating procedures, does it make sense to do them even if they're asymptomatic or even if they're really clear, or let's say family member that you've seen throughout the days, okay, let me just bring you to the clinic. I'll do some respiration on you because it hurts. Are we even gonna go near the fire in that sense? Or are we just gonna stay away from it until all of this is settled?
Again, it's a question of how do you want to risk your practice? How do you
All
want to
right.
risk people inside the clinic and then the family of the dentist when you go back home?
Yeah.
It's hard kasi to put a guideline when we don't know exactly what's gonna happen if you get the COVID. So I think
Yeah.
ako most probably sa clinic namin, most of the people are very um careful in treating everyone, even family members, even old patients, even patients that have been coming over the years. We're still very careful. So we still screen them out, and then we do all the necessary triaging, and para rin it's safer for us and for the patient.
All right. So it's a very interesting point. Again, for the dentists out there, we would like to emphasize that we are on top of the list who are high risk. Not even the respiratory physician, not even those people who intubate, the anesthesiologists are higher than us. Those people are the ones even who are getting easily infected from the hospital. And I think we have about more than 100 health practitioners already passing away just because of this virus. And we're not yet counted. So what more if we just dive into this unknown, and it's very dangerous for us. And I think that's a very interesting point, or very nice point that Dr. RJ said, that we can either be infected, we can either transmit it to our patients, or we can transmit it to the people around us. And you as an individual right now that you're staying home, what you're just thinking is that I don't want to be infected. When you go into your practice, you're not just thinking about getting infected. You must also think about those people that you might get infected, and also that you might infect, and also those people that you might infect around you. So it's a very interesting point that you said, how dangerous actually and how serious this actually is. So what you recommend is zero aerosol generating procedure. Think that almost all patients, all patients are infected. And lastly, you can get infected, you can infect, and you can also, you can infect your patients, and you can also infect your household. All right. So maybe this is a question that most people would like to ask. How does it feel to be in the front line? How does it feel to be, is it nerve-wracking? How could we relate or identify to the emotions that are going around? You can do all the triaging, 1, 2, 3 layers, put in your PPEs, and then here you go, you start it. You know that there's going to be saliva around. How does that feel exactly?
Honestly, it's very scary. You get paranoid every time you cough or you feel an itchy throat. There is always this fear na, oh my god, I might have it already, or I am infecting people at home or whatnot. So it's actually very scary, and I don't know how the frontliners, the physicians and the nurses feel. Kasi if I am feeling the paranoia itself, how much more for them, diba? At least we are getting a line wherein we can accept some patients and then defer some patients. But for them, hindi kaya eh. They get to address or give attention to all patients, diba? So it's very scary. It's very, very scary.
If I may just return back to Ma'am Jet, from a general standpoint, what do you think we should feel as individuals? The Philippine culture is much more on the emotional side. Should we be paranoid? Should we be worried? Should we just jump into it because we need the money already to sustain our livelihood? Should we be cautious? How should we feel about this? What's the correct emotional response with knowing all these information and being in this kind of genre of job or profession? I think you're on mute. Command center, please unmute.
Okay. Yeah.
Right.
Okay. Going to your question, Pao. Okay. I think I can feel both sides because being a practitioner myself, we all know that, especially for those who use dentistry as their bread and butter, I can understand the economic situation because no patient, no pay, and definitely that's what we use
Yeah.
for subsistence. And then, of course, for a lot of us, you have your overheads to be contend with, you have the rent and so on, the electricity, the electrical bill. So there's a lot of things to worry about, but definitely the economic factors there. And you can't blame practitioners for wanting to go back to normal, as normal as possible, given that kind of scenario. And many of us only have our dental clinics to rely on. So having said that, of course, there's that part of us that really wants to go back into practice.
Yeah.
But given the extent of the problem and given how infectious this thing is, and given the fact that everything's really quite unknown and that we don't have any cure, we don't have any vaccine, and the rate at which it infects other people and the extent of damage that it can actually cause, because even after you recover from the COVID, there have been studies which show that there is already permanent organ damage post-COVID infection. So even if you survive being intubated and all, there will be already repercussions to your health overall. So we cannot discount that fact. There has been kidney damage reported, liver damage, and the reports are continuously coming in. And given that kind of scenario, given the fact that this is highly infectious, that it is still under control by any means, that reinfection is possible. At this point, I would, actually worry about the whole situation. And again, of course, we cannot avoid treating patients, especially if there is already an emergency on hand. Of course, it's our duty to treat this patient, and we cannot discount that fact. But again, I think we have post ECQ. I think we should be more cautious and be more selective with the cases that we handle, and weigh everything, the pros and the cons. Are we willing to risk being infected and infecting other people in the process? When all you have is, for example, composite filling that you need to do, or even a brace adjustment, I guess, or prosthetic or prosthodontic work, which doesn't necessarily merit a dental emergency. I mean, if this were life-threatening or causing extreme discomfort, then of course go ahead and treat in the shortest and quickest way possible. I'm sorry, but if we need to do extractions, and so be it. But bear in mind that if you do an extraction, this time you're doing blood work. So again, the chances for infecting other people and reinfection and so on is there. So given that kind of scenario, it's really not saying to people that no, don't go back into dental practice, or no, you can go back to life as it was. I think it's you as an individual making your own personal choices and weighing things out. If it's really worth the money, given the fact that the risk is really there, we cannot remove that from the dental practice. As you mentioned, we are at the highest level of risk, and because the work that we do goes into everything that will qualify us to be under that high risk level. I mean, we work on, as I've mentioned, in the oral cavity. It's the entry point for the respiratory tract. You have your salivary glands. You have direct contact. You cannot practice social distancing. So even if you put all these suctions in your clinic, and that's what I've been discussing with you guys before this webinar. I mean, I think there are these suctions being sold to lessen the amount of aerosol in your clinic setup or whatever. For me, that's not even the point of.
I think we lost Ma'am Jet for a moment. She's going to be online in a very short while. But let me just put it like this, that I think one of the takeaways that we can take from Ma'am Jet is, from Dr. Jet, is that we as dentists can not only be infected via aerosol generating procedures. That's not the only way to get COVID. The other way to get COVID is just merely by contact or physical contact. And whatever it is, even if it's a non-aerosol generating procedure, there is still a high chance that you can get infected just by contact. So it's a very interesting point, because at the same time that I was asking for the response or the correct emotional response that we should have in this kind of situation or pandemic, we kind of think that should the need for money outweigh the need to prevent this? And I think we of dentists would know best that prevention is better than cure. So the consequences of getting the virus is actually higher and more expensive, and it's actually more of a waste than it is if we're gonna just jump into the practice. Okay, so we lost Dr. Jet for a moment. We have to understand that she's coming all the way from Canada. We're trying to establish contact again. Pretty sure we're gonna get that back in a very short while. But for the meantime, let me just go back to Dr. RJ Dulay again, who's working in the front lines of the East Avenue Medical Center. Now we've talked about the quarantine phase. Now I want to talk about the post-quarantine phase, where when the lockdown is supposedly over. The first question is again, which would be the same question in the first part, is who should we handle? Who should we handle in terms of emergency cases? How exactly, for just a review, I mean, how exactly this triage happen or work?
I think before we dive into the classifications of cases that we can consider emergency, I think it's safe to discuss first the transmission of COVID. You mentioned earlier that it's just mere contact. Actually, when you think about an infection, we have infection control protocols set. These have been the standard precautions, diba? The PPEs, the gloves, the masks, and all that. But with this kind of condition, kasi, we need to do additional precaution, which is what we call transmission-based precaution. So with transmission-based precaution, it has three aspects that we need to consider. One is contact precaution. Second one is droplet precaution. And then the next one is airborne precaution. So when you say contact precaution, let's say, for example, a patient is positive, technically should be or he will be shedding viruses. So if he coughs or touches his face or nose or mouth and then touches any surfaces, when another person touches that, he could or she could get the virus. So that's contact transmission. Now, the second one is droplet. Droplet is anything above 50 micrometer.
Microns?
Yeah, 50 microns. More than 50 microns. So basically, it's bigger. So that is when a patient sneezes or coughs. So the thing is with droplet, it falls to the ground faster. It doesn't stay airborne. So when a patient sneezes, as long as you're 2 meters away from the patient, and given that the patient is wearing mask and you are wearing mask too, the risk is moderate to low. Now, the second transmission is through airborne. And that's where the problem comes in our practice. Basically, 70% of procedures we do in the clinic are of airborne type. For example, we do scaling, we do fillings using the drill, surgical extractions using the drill. By mere usage of those kinds of equipment, we produce airborne type of transmission. So I think doon it plays where we have to consider how to treat these patients. So again, going back to your question with regards to the classification, in our practice, in our clinic, what we normally do is just try to classify four things. I think there is one from Australian Dental Council, Dental Association, that they are only allowed to do level 3 types of treatment. This is actually very informative. I've compared this with the ADA, yung American Dental. The American Dental posted flowcharts. It's kind of complicated if you look at it in a way where, should I do this, should I not do this? But with the Australian Dental, it's relatively straightforward. So I think mas okay siya gamitin in terms of a reference. So with the level 3 type of restriction, it shows there that you are allowed or you're given permission to treat patients who are basically having or have of one of the 4 types of cases. One is bleeding, spontaneous or uncontrolled bleeding. The second one would be pain that is unaffected by typical analgesics, infection, and the other one is, I think, trauma. So normally, we get calls, and then we try to classify patients based on that high priorities, based on that consideration. And then if they come into that types of cases, we normally ask them to come. Dun lang namin sila papupuntahin. So if they are not of urgent type of cases, we give them instructions and probably tell them to come back when it's good time for them to be treated.
Okay. This is just getting worrisome by the duration of this webinar. Okay, so it's very, very interesting point on how we should screen our patients, not only by their symptoms, but also by their needs in terms of seeing us. Dr. Jet, and this is wonderful that we have some type of diversity. Dr. Jet, she comes from a standpoint that mere contact with the patient or mere contact on the surfaces of the patient, what the patient touched, this could already get you infected. So you don't need aerosol producing, aerosol generating procedures in order for you to get infected. So even if you're using these suction machines or PPEs, it still does not guarantee that you're still safe. And Dr. RJ has another take that still there are some patients with high priority, as according to the list that is posted right now. In as much as they would be needing some sort of dental attention, our function as well in this society is to meet those needs. But of course, I think at that time that you decide to face your patient, that it's really something that is according to your own discretion. And with that own discretion, even with these guidelines that are available, we must still practice utmost care to the higher than highest level that we could. So let me just get some questions from the public. Dr. Restiluz Mejorada, he said, you mentioned we will consider the patient to be COVID positive, so we will require them to undergo COVID test. What if not all patients can afford the test? I think, if I may answer this for you guys, first of all, is if you want to keep yourself safe, the best way really is to in another context is to abstain. So even if you cover yourself or you boost yourself with all these vitamins or whatever, it's still no guarantee that you're going to be safe, as Dr. Jet pointed out, that even healthy individuals can be affected. So if you're with that mentality that you're considering all patients as positive, basically means that your approach to the practice should be seen through this perspective, that all patients are actually infected and you can be infected as well. Now, to go and answer about the question on the test. Yes, what if the patient can afford the test? Okay, let's put it in that context. How long then would the patient need to for that result to come back? So for the reliable test, it takes about 5 to 7 days, if I'm not mistaken, Dr. RJ, through the PCR via the RITM. It takes about 7 days for you to get your results. Now, anything could happen within that 7 days. The patient, even if they get the test and they come out negative, but within that 7 days they get infected, well, hello, yeah. You're still gonna get in trouble. So I think it will still be best that you protect yourself at all times and at all costs. So, and then we have another question by Roxanne Gallego. If it's safe for us to consider all patients as COVID patient positive when they enter our clinics, what kind of PPE should we be using? Are N95 masks required, disposable surgical gloves, etc.? Should a scrub suit be enough? And we're going to go into that segment right now. Dr. RJ, could you just walk us through into how you handle your patients? What are the layers of the PPE, and what's the setup of the clinic? UV lights. I think this is where people are really going to ask UV lights, and I'm also going to ask. I think Dr. Jet also gave her her viewpoint on UV lights and also suction machines. According to studies, it takes out about 40 to 60% of the aerosols. It's not 100%, I suppose, unless you're in a controlled environment, like in a chamber. But then, again, as Dr. Jet pointed out, is that it doesn't even, you don't even need to do aerosol producing procedures, or aerosol generating procedures to get infected. It's just merely by touch. So merely by touch, basically. So Dr. RJ, how do we protect ourselves? What are the layers that we should wear? How do we protect? What's the right kind of mask? Disposable, non-disposable PPEs, N95 mask, surgical masks. What's the right way to go about this?
Again, before I start giving
can we
advice,
start with the personal? Okay, the personal, not the dental chair. We're gonna go to the dental chair later. I'm sorry. Okay.
Yeah. Before I start giving out advices, I would like to tell everyone that these are interim guidelines. So
yeah,
in the coming weeks or months, this may change, but we have been basing our protocols, especially at East Ave, based on this interim guidelines and based on the science of what we know of COVID. So again, this might change in a few days or weeks to come. So but basically, the science behind PPE has been there for centuries, diba? We've been using standard precaution, universal precaution for the longest time. And I think it's still the same. But since we're dealing with a virus that, it's new, it's novel, what we try to do is add a little more layer of protection, by doing the transmission-based protocols. So again, I get the point that Doc Jet has been discussing about contact, even without the aerosol produced, just by mere contact with an infected bodily fluid, you can actually get the COVID. So basically, what we do in the practice is the standard precaution plus transmission-based precautions. So personally, in our PPEs, what we normally wear is basics. So you have the masks, the goggles, and the face shields, and then a head cap. We usually wear the scrubs, and then on top of the scrubs, we wear a gown, and then the shoes. We wear either protective covers for our shoes or a shoe that is specific for just the clinic. You don't wear it outside the clinic, you leave it there. So yes, this is basically what we are using right now. There is a question whether you need to do or you need to wear a surgical mask and an N95 mask. Well, some study would say that there is a requirement to wear N95 because N95 filters 0.3 microns and viruses such as yung corona is 0.125, I think. So 95 means it filter out 95% of anything you breathe in. So for us, because of the scarcity of PPEs and masks, we try to do what's efficient. Again, this is backed by some science. If we are going to do a non-aerosol producing procedure to the patient, we can or we use surgical masks. But you have to put a face shield on top. The face shield provides a second layer of protection. Because when you use just the goggles, if you're using just the surgical mask, again, it's kind of thin, filter out 80%. So you still have that 20% chances of getting the virus. So if you wear a face shield on top of a surgical mask, it gives you an additional type of protection. Now, N95 situation, we reserve that for AGB procedures because again, it gives us more protection. So if you're gonna do generate some aerosols, we thought that it could be much better utilized than the surgical mask. Again, on top of goggles and on top of a face shield.
Okay. So very specific for non-aerosol producing situations or procedures, you don't need an N95 mask, but for aerosol producing situations, we need an N95 mask or even higher, correct?
Well, this is in consideration with the amount of supply. Again, we cannot tell them to this and that, but you have to use what's there.
In a realistic world.
Yeah, in a very realistic world, because we understand that there's a lack of masks going around for healthcare practitioners, and we don't want to add on that. So as much as we want to use N95 all the time, it's not possible these days. So us in the clinic, we try to reserve it for procedures that we know is going to be a high risk of getting the virus.
Okay. So one piece of advice is that N95 mask, even if the manufacturer claims that it's an N95 mask, that's pretty hard to prove as well, because I'm not sure with how fast these masks are produced, if they are being done with the specific or precise highest quality way of doing it. We still cannot assure. So don't just trust N95 just because it's on the packaging. Make sure that you get something from a reputable and true and genuine N95. But I have a stupid question that can I double mask? Can I wear 2 surgical masks? Or 3, or 4, or 5? Would that help?
Before I answer that question, though, another thing to point out with N95 is that it's fit specific. In the States, I think they have to get the fit of your face so that you can get a better protection using N95. If it doesn't fit you, it's not protecting you. So before you use a specific brand of N95s, you have to initially fit it in your face. Does it cover your mouth, your nose, and it's not leaking on the sides? Because if it does, it's basically just surgical masks. So it defeats the purpose. So I think it's very important before you buy the N95s, which is actually very expensive, try to buy one first and then fit it. And then if it fits well, then get some more. With the multiple masks on top of another, I don't think that's efficient in regards to the supply and demand right now. I think it has to come from a place where you just have to be conscious of yourself, of what you're doing, and of your patient. If the procedure calls for an aerosol producing treatment and you don't have an N95 mask available, I think it's best to say don't do that procedure anymore. Again, it's a matter of risking yourself to be infected. Diba? I don't want to tell you na, it's probably safe to say to wear 5 masks just to do an aerosol producing, when in fact you're not protecting yourself. So I think if you don't have the right equipment right now or the right PPEs right now to do these kinds of procedures, I think better not do it at all.
Okay. So I think that face mask issue may be settled. So again, just to emphasize the point, N95 or higher must be used for aerosol producing generating procedures or AGPs, and then surgical masks for non-AGPs. Now, next question is, there's a lot of face shields that are being created. Some are makeshift, some are just made out of something. I think we of all would know what a good face shield is. Would you recommend any type of face shield? Is there any need to think about this face shield, or is this just a mere barrier that could just reduce the chances? how yeah.
Face shields are part of PPEs. It's very, again, remember, it's airborne. It's around 0.125 microns. It's that small. So if you have exposed mucosa, such as your eyes, you'll have the chances of getting it. So the face shield provides additional type of protection for your face that's not covered by the mask and not covered by the goggles. So I think it's safe to say that it is a vital part of PPE. So especially if you're wearing just eyewear, I myself, I just wear an eyewear and I put side shields on my eyewear to protect me from splashes, and then a mask, and then a face shield. So kind of you go away with using the goggles, because there is a difficulty when you're using goggles, especially if you're gonna do something of a long procedure type of treatment. So what we do, or what I personally do, is I wear my glasses and then put side shields, and then a mask, and then the face shield on top.
Okay. So face shield and goggles are a must. Is there any type of goggles that we should use? Is this just the mirrors? Can we use sunglasses? Those sports sunglasses, or should it be like industrial grade goggles with those breathing holes on the side?
I'm not familiar with any other types of goggles other than the goggles that is recommended by other guidelines from standard precaution, says that it has to have side shields. So if you're wearing prescription glasses, as long as you can buy those side shields that you can insert dito sa side ng eyeglasses natin, that's actually more than enough to protect you from splatter and going into your eyes. So I think because you have to understand, dentistry is very access and visibility reliant. So if you're gonna use the hardware eyewear or the goggles that normally is used by other people, it's difficult to see. So I think it's safe to say pwede yung prescription glasses as long as there is side protection.
Okay, now just a quick question with a quick answer. How about patients? Do they need goggles as well? From a neutral standpoint, without the COVID, we have been putting goggles, or we're supposed to put on sunglasses or eye shields on the patient. How more important is it right now that that the patients wear one? Does it increase the need?
Well, assuming there is always an assumption that the infection is coming from the patient. So if the patient is positive and he is producing the aerosol, technically, if it comes in contact again to the mucosa of his eyes, it's basically the same. But again, that does not say that you don't have to give them the protection for the eyeglasses, because the eyeglasses is actually to protect them from other stuff like your sharp instruments or needles when you're trying to suture, or broken burrs that flies out from the micromotor or the handpiece. So I think that's not actually the question anymore. Just have them wear goggles for any other reason other than COVID.
Okay. Now we have a good question here from Dr. Bernadette Tuaño. Can we chemical sterilize our face shields? Should they be disposable?
That actually depends on the manufacturer's instruction, because you have to remember, especially right now, I do get a lot of face masks from private institution that donates it. So technically, you don't know what type of material they're made of. So what we do is for goggles or for face shields that come from legit sources, there is an actually instruction on how to clean it. If it tells you to it's okay to disinfect, then you can disinfect, but use whatever they are telling you to use. If it's a one-time use, then you have to throw it out after each patient.
Okay. And another question here by Dr. Simon Pahang. Is alcohol enough to sterilize the face shields after each patient, or do we have to discard it after using? Oh, wait, we've answered that question. But alcohol, Lysol, I think there are wipes that are specific to coronavirus type, and my wife got that kind of wipes, and not all wipes are capable to treat it, right?
I think it's a question of whether it's gonna be effective for. I mean, my contention is coming from, does it kill spores? Diba? If it's a sterilization, does it kill spores? So if it's disinfecting, does it kill majority of bacteria or viruses on that surface? So I think us dentists have to really learn how to read proofs that it can actually be effective right now, because there's a lot of things going on. Minsan nakakalimutan na natin to read on how effective is it, because most manufacturers would market their products that is really good in paper, but in reality they don't have any data to back it up. Like, for example, the oral suction, I have nothing against the extra oral suction, but I need data. I need data that it really filters out everything that it sucks in. And then remember, the extra oral suction, after it sucks out the aerosol from the mouth, it also releases it inside the clinic. So if I don't have the data that tells me that it has eliminated the viruses or the bacteria that it sucked in, I'm gonna be much worried, because it's gonna spread the airborne bacteria or viruses again in my clinic after it sucked it out. So, diba?
A very, very interesting point that, you can suck it out of the mouth, but then the exhaust system of these exhaust systems blow it out around the clinic. So is there any guarantee that this air that is blown out, is it clean as well? So a very, very good point, which has to be studied, and definitely has to be studied before we even purchase these very expensive machines. Dr. Jet, I believe, has an input on this question. Ma'am Jet?
Yes. With regards to alcohol, no, the use of
Ma'am,
alcohol.
can you increase your audio, please?
Oh, sorry. With regards to alcohol, the use of alcohol is very controversial, even for ordinary hand use. In fact, remember that they recommend hand washing more than alcohol. So that means that alcohol doesn't really guarantee that you eliminate the virus altogether. On a very ideal setting, I would actually think that everything, as much as possible, should be disposable, because again, it's not just simply us going out into the street and encountering people who are COVID positive in an open setting. We are talking about direct contact with salivary fluid, with the oral mucosa, and touch contact. Everything that's supposed to put everyone at high risk within a dental setup is there in our practice. So if we understand the financial limits of having things being disposable, but then again, if you really want an ideal setting where you have really minimal risk, the safest answer would be to dispose everything that you use per patient. But having said that, definitely, well, bleach can help, they say, although it's still not an assurance, because there have been patients who have said that they were using bleach, they were using alcohol for their groceries whenever they purchase something outside and whatever, and they still end up getting infected. So again, I think we have to come from a mindset that if you really want minimal risk, I mean, there's no way around it. I mean, of course, you try to do everything possible, create all the barriers, and I do agree with RJ that the face mask and everything, because you're talking about splatter, you're talking about contact. But I think it goes without saying that even if we do all these things, we are still at high risk, because otherwise, I mean, in a hospital setup, which is much more strict than a dental setup, people still get infected. Health workers still get infected, and they already practice high sterility, high disinfection, all the barriers set up. And this is with minimal contact time with patients. What do they spend in the triage? Maximum of 30 minutes? For us, remember that our procedures last longer than just a mere 30 minutes. And even with that, we are, again, the distance that we have to keep between the patient and ourselves is pretty short. So that poses a bigger risk on our part. So we're not saying to stop all dental practice. I don't think that's possible, especially when an emergency case comes to you. I don't think there's any way you can say no if it's really a life and death situation. And we are given those instances. But again, it's a matter of weighing in. How much risk are you willing to take? If a patient comes in and tells you, oh, I want to have a denture done, or I want to have a jacket crown done, and there's no discomfort whatsoever, are you willing to put yourself at risk? Because there's no assurance at this point. The studies that are coming in are trickling day by day. Again, like what RJ said, things can still change. This is on an interim basis. I mean, what they discover today may not hold true tomorrow, because everything is just entirely new. And the data may change, the numbers may change. So you have to put that into consideration as well. But to say that we can do everything, but to assure the audience and the practitioners that no, you minimize all risk if you buy the errors. No, there is no such thing. The moment that you see a patient, definitely consider that you're putting yourself on the line. That's the truth. Again, in my opinion, there is no way to say that no, you are minimizing. No, I mean, given how this virus works, there's no easy way out of it.
Excellent point. In combination with Dr. RJ's opinions on how we should handle this right now. Again, to everybody, there's not enough evidence that PPEs, these high evac system, or even the UV lights. So we're going to go into the UV lights later. That there's still not enough scientific proof that these actually work. I mean, just think about it. When these guys come up with these machines, I don't think that they're gonna put this in a scientific lab and get a strain of the coronavirus and then test it if it doesn't blow anything around, because I think it's I think it's kind of stupid that you actually try the actual virus. So just so to say that in relation to the virus itself, you can reduce the vehicle, but you can't reduce down the virus, which I think is very important as we consider going back into practice. Do you echo that, Dr. Zed and Dr. RJ?
I think I could agree with that.
Yeah, I think I would agree with that. You can reduce the possibility, but you cannot remove the risk.
Yes, that's true.
And I think that even with the UV light, I mean, put it this way: if all these things were put into place in a hospital setup, shouldn't the rate of infection have gone down a long time ago, right? Exactly. The mere fact that you have a lot of health workers getting infected on a daily basis and even dying because of the infection means that all of these do not put your risk to zero. In fact, the risk is still pretty high. And being frontliners, and we are frontliners. Unfortunately, we're in a profession that doesn't give us much space to move in. I mean, if we are to keep with what we are supposed to do, you have to recognize the fact that once you get into a clinical setup, then you get back into practice, you are putting your life on the line. That's a fact.
All right.
Cannot remove that.
Right.
Even if you put all the means of disinfection out there in your clinic, all the suctions, all the UV lights, there is no 100% proof that these all work. And I won't be surprised if people start going back into the clinic and you hear of dentists getting infected. I wouldn't, and at high numbers. I really wouldn't be surprised.
So very, very, very good point that we're establishing right now, that it's really a risk, and more studies have to show that we are really safe within our practices. I think, as Ma'am Jet said, and I would like to stress that the hospitals are like are the institutions that actually practice the most kind of sepsis or infection control. That's where diseases basically just go around. So for them to be practicing that at a very high level, and now that we have the COVID, they're practicing it to a higher level than they were before, with all these PPEs, even walking around the corridors, they're already wearing PPEs, unlike before that they're just wearing their scrub suits. And to put this into perspective, these people are still affected or infected by this virus. What more in our situation, in our own practice, where we're not practicing it to like that level, and even if we increase our ways of disinfection or infection control, it's still really the risk is still very high for us to take on. Okay, so if I may go back to the PPEs, Dr. RJ, head caps, disposable or washable? I'm gonna go down. I'm gonna start down from the head, but I'm really gonna go down. So head caps, disposable or washable?
I think I'm gonna go with what Doc Jet has told, that everything as much as possible should be disposable. Again, there is no assurance if you take it off, wash it, and then it's gonna be 100% COVID free. So it's safe to say for head caps, it should be disposable at least.
All right. So we have this existing government instructions to properly dispose our waste, which are not really collected. How exactly do we, I mean, in our own practices, I think it's going to be different in the hospital because you have a proper waste disposal in that whole system. But in our own practices, this is kind of a challenge because it's not every day that these government institutions are collecting the trash from our clinics. But how do we go about this in terms of disposing and keeping the public safe? How do we dispose of these disposable stuff?
I'm actually not fully aware of our guidelines here in the country, but since I took some exams abroad, what I know is you can keep it as if it's an infected waste. So you have to put it in a yellow bag, and then I think here in our country you have to contact a specific type of waste disposal company that will collect it for you. So, given the fact that it's infected, I think you have to have an area to keep it for a period of time before the collection. So, I don't know how it's going to work for private practices, but probably you can put it in I don't know, in a safe box or whatever until it gets collected. But again, it has to be on a yellow.
That's dangerous to keep it in there. I think it's still dangerous to keep it in there as well.
Yeah.
Okay. And this goes also for the body PPEs or upper body PPEs, and lower body PPEs. Disposable or washable? I think we've made it a point that disposable is the best. Proper disposing is the next. Now, how about washable? If we want to insist on washable and we're not doing aerosol generating procedures, how do we go about washing this? Is there any recommendation on how we wash this? Can we put this in our dish, in our washing machine?
There is a certain I think there is a certain guideline for washing PPEs, especially for the gowns, because in a hospital we do utilize washable OR gowns. So what we normally do is send it to a specific washing company, and then they send it back, and then we sterilize by the CSR, sterilize those OR gowns. But some guidelines would say, I'm not sure what guideline was it. I'm gonna send it later on. That unsterile gowns is okay. Unsterile washable gowns is okay.
All right. And that leads us to the next point about gloves. How about the gloves? Should it be here in the CDC guidelines? It says that it's supposed to be. I mean, it can be non-sterile. There are some studies that study that examine the permeability of these gloves. Which one do we go by? Do we go by the latex, the nitrile? Nitrile has is very that's easy to tear. What's the other one? Vinyl gloves. Which one would you recommend?
Again, I don't want to recommend any specific type of gloves
Yeah.
for that matter because it's hard to give guidelines right now. What I would say is base your gloves to the type of procedure that you need to do. So, for example, if you're gonna do an examination minus blood or minus any saliva fluids, just mere oral examination, you can go away with the exam gloves. If you have the nitrile, the vinyl, or the latex one, that's I think gonna be fine. But if you're gonna be doing a procedure that will expose you to a lot of fluids and blood, I think it's safe to say to use the surgical gloves because one, it's thicker, fits well, and it's gonna give you much more protection than the exam gloves.
Right. And again, the correct, like your masks, it must be the correct size. I see a lot of practitioners who practice with very loose gloves because they don't like the comfort of, they feel that it's uncomfortable for it to be tight. So make sure that you're wearing also the correct size of gloves. And let me just go quickly into this. The wearing your PPEs and removing your PPEs should be done by the dentist or by the assistant.
I think we have to also consider the sequence. There is a specific sequence of wearing, donning the PPEs, and removing the PPEs. Because if you think about it, if you remove it in such a way that haphazard lang, you remove whatever is inside, you forget about which parts are more infected with the virus and which parts of the PPE is not. So I think we have to discuss then the sequence of putting it and removing it. So I think there are several guidelines that tells us that you have to remove first this and remove this and that afterward. So I think this one, the one posted, tells us that when we have to go to the donning first. There. So if you have to put it, the first thing you need to put is the gowns. So the gowns, and then the mask, the goggles, and then after the goggles, the eyewear, and then lastly the gloves. And then when you have to remove it, it's the reverse. So you have to remove the gloves first because that's the most infected part of the PPE.
Yeah.
So I think
and again,
it's safe to...
there's a proper way to remove the gloves.
Mm-hmm.
Yeah. Go ahead, doctor.
So I think the proper way of removing the gloves is to peel it reverse so that the exposed part is the one that is in contact with your skin, and then the unexposed part will be the one you're touching, and then when you throw it, it minimizes the risk of you holding the exposed part where it was exposed with fluids and stuff like that.
Yeah.
So it's relatively easy to say the least. Yung sequence of putting it on and removing, I just think it has to be done in a way that it is repeatable. So pwede nyo siguro yan ilagay in your clinical areas. So by the time that they need to see it, they could actually just follow it.
Okay. All right. So very interesting point on how to wear and remove. Back in the old days, we used to wear these PPEs to protect the patient from any infection that they could get, right? But nowadays, it's not only about the patient, but it's actually about ourselves as well in terms of protecting the people around us, including our assistants and also their families and also our own families. So now going a little bit lower, how about foot sleeves?
There's actually a study in China that says they found COVID viruses in areas where there were no positive patients around. Like they say health workers working in ICUs and wards of COVID positive patients would actually spread the virus through their footwear. But the limitations of the study does not say whether that amount of virus could actually be transmissible or how much virus was there. They would just say that there was, in fact, viruses in the footwear and the area where the health workers go into. So safe to say, I think it's best to wear some sort of protection on top of the shoe or footwear that the health workers are wearing during the procedure, or I don't know which one is more efficient, literally clean the shoes after each procedure. So
Yeah.
it's hard to say a specific guideline, but I think we just have to take it as a way of protecting ourselves. If viruses can get into other parts of our clinic because it is gonna go down to the floor after it's airborne, then
Mhm.
protect yourself by either wearing footies or shoe cover, or clean the shoes after each patient.
All right. So from what I believe, in the hospital setting, you have to have a different set of shoes in the operatory or whatever you use inside where you meet the patient. So this is not a common practice in the dental practice. I personally have not seen any practice that does this, that they change shoes before they go into the operatory itself. But I think it's one thing that's interesting in terms of protecting ourselves and protecting any transmission of bacteria. If I may just go back to Ma'am Jess for a minute here. From what I know, viruses need a host in order for it to just go around. But it seems like in this study done in China, as Dr. RJ cited, viruses seem like they don't need this coronavirus. Doesn't seem like it needs a host. Is there any wrong perception into that? How does that
No.
happen?
What the studies are showing now is that the virus can actually survive for as long as 15 minutes in a non-living or thing, not even organism, but non-living thing. But the thing is, this is the thing. It can stay in, for example, a surface for at least 15 minutes. But once it gets into the host, then it gets activated by introducing its RNA into the host cell, and then eventually converting and introducing its own DNA, its own genetic material into the host cell. That's how all viruses work. And this is a retrovirus, so everything starts from its own RNA and then being developed into a DNA, but within the host cell already. And that's how it practically meddles around with the immune system and with the host itself.
Mm-hmm.
By introducing a totally new set of DNA, which in turn will produce a new set of proteins, which your body is not used to. But yeah, it does survive in, and there are different kinds of surfaces where it gets to stay. I think the least receptive would be copper things with copper or copper lining. And then the ones where it stays the most is, I think, plastic. So, and again, that would have some relevance in our dental practice, because a lot of the things we use are made of plastic. So we have to bear that in mind as well.
Yeah. Okay, so going back to the
face shields are plastic, by the way. So yeah. So there too, you have to keep that in mind.
Okay, so very interesting point of view. It's this virus is it's actually it's crazy. it's really scary. It's really scary. So
it's different.
It's not something.
Different. It's really challenging to study it. Right.
It's very different. Yeah.
I think if I may butt in, there's a very good question here from Al Madrid. The question was, shall we change our PPE gowns per patient? When you think about it, again, it depends on the type of procedure that you will do and the amount of PPEs you have and what you have available right now. So in our practice, we plan, this is an ongoing protocol that we're trying to devise. We plan to divide the clinic into two separate parts. So one is specific for just aerosol producing procedures, and then one is for consults, triage, and non-aerosol producing procedures. So with the current situation of scarcity of PPE, if our setup is we're gonna be putting specific duties for each dentist. Like for example, Monday there'll be 2 dentists doing triage and consults, and then there'll be 4 or 3 dentists doing the non-aerosol producing treatment, and then 2 for aerosol producing. This is a way of minimizing exposure to other types of procedure that may risk them, and also separates the area, containment area, so that if you're gonna do the aerosol producing, you'll be contained in that space, and then the aerosol produced will not spread to other parts of the area. So going back with changing the PPEs, if you're gonna do just consult or just checkup or examination, I think it's safe to say that you can keep the mask on for that whole session, as long as you're wearing the shields. But with the exposed areas, such as the gowns and the gloves, I think you have to change that. So with the mask, as long as it's one session, one mask, and then it's covered with a face shield, you can keep it on. But for other parts of the PPE that's going to be exposed to the patient, like for example, the gowns, the gloves, and the footwear, you have to change it every patient, regardless of whether you're doing just consult or non-aerosol producing or aerosol producing procedures.
I think Ma'am Jet would have input on this part of how long you can use these N95 masks.
N95, I think, lasts for 10 hours, so definitely you have to change it. But again, when in terms of changing your PPEs, I also think that you have to put into consideration the chances of you contaminating the next patient. So
Yeah.
again, like with what RJ said, if it's an aerosol procedure and you think that there has been splatter on some part of your gown or your face mask or whatever, or even anything near your hands,
Yeah.
which can touch the next patient, then I guess definitely you'll have to change. But then again, of course, you have the practicality to consider, and given the fact that we don't have much sources out there, then of course you have to be very choosy and very critical with the cases that we handle as to whether or not it will necessitate a change. Because if this were a regular scenario and we had a huge supply, then I guess the ideal setting would be to change per patient. But given the limitations that we have right now, be very, very particular and be very, very discerning when it comes to changing your PPE. Because it's not only for our sake, it's also for preventing cross-contamination and adding to the numbers that are already out there.
Yeah, we also have a responsibility to flatten the curve as dental professions. And at the same way, I would like to substantiate those answers in a different perspective. Like, think about it as if you're the patient. If your dentist did not change the PPE and they come in wearing the same PPE they were wearing, would you still sit down in that chair? I think you would run away. I would personally run away. So I think we should think about our patients more than we are thinking about the practicality. Again, the best way to do this is to stay away from it. All right, and so we're almost on the tail end of this webinar, and we still have a few questions left. Dr. RJ, how about the scrub suit or the clothes that we're wearing underneath? Can we wear these clothes outside as our street clothes, or should we remove and change them even if they're covered with a disposable PPE?
I think we have to again understand that this is an infection, and we've been doing standard precaution way back before COVID arise, or way back before we had COVID. So that is what we've been doing before it. I don't think that's even a good question of wearing your clinical clothes outside, because remember, the virus can get attached to the fabric of whatever you are wearing at the time of the treatment. So definitely, if you go home wearing the same clinical clothes, once you get into contact to someone, whether you get a hug or whatever from a family member, they can get the virus from that. So I think it's safe to say that whatever you wear inside a clinical area should be removed on that area, and then change clothes when you get home. So, mas preferred natin na yung damit na gagamitin natin inside the clinic is the same clothes we just use for treating, and then when we go home, treat clothes ulit.
All right. So I think we're done with the PPEs. To go into the patient setup, I think we've tackled the aerosol evacuation system. I think we established already that yes, it can take in aerosols, but we don't know if it's blowing out these viruses back into the environment, and it could affect or infect everybody inside the clinic in a whole different way. And then, so I think if there's anything you want to add about this, or is that substantial?
In terms of like the air filters, for example, another question I would have there is, how do you dispose of the filters? Remember that the viruses can survive outside a living organism. So if it does get sucked in, or at least that's how we understand how these filters work, how's the disposal? And how would you touch it? Wouldn't removing the filter from the machine actually expose the virus all over again? So these are things that we have to consider. And again, there aren't any substantial studies on whether or not these really work. I mean, of course, these are studies being released by the companies who want to sell them. So understandably, the studies would all be positive. Not that I'm saying that it doesn't work. I would like to think of it as in this manner, that it will work if this were some ordinary virus or this were some ordinary bacteria. Not that it wouldn't have any value in your clinic. Of course it would. But to give us an assurance that it will definitely lessen the concentration of, say, the COVID, if that's what you're particularly worried about, I would say give this as a recommendation. What's the difference between buying that aerosol and having one patient enter your clinic at a time? So if, for example, you set an appointment for 2 to 4, make sure that there's only one patient there. Then you get to manage social distancing.
Yeah.
So it's the same thing. You minimize the aerosol that's there. You manage social distancing. Wouldn't that be the same as having a suction inside your clinic? It's the same thing. Or having your windows open instead of having an air-conditioned setup. These are things
which won't be really practical with the humidity.
Yeah,
exactly. What I mean to say is,
I know. Yeah. I'm really worried on that. I'm really worried on giving an assurance that these aerosols are give added value. I really don't think so. Because again, I will go back to contact. Even if you have all the suctions in the world, the mere fact that you hold your patient, you touch your patient, and you touch your patient's mouth already increases the risk on your part. So,
yeah. So good take on this is that one take is that one way to look at this is that we have the intake of this aerosol machine, which we want to think, what we solely think about. But what we're trying to say right now is that we also have to think about the outtake of that machine and how it blows the air around. So particular to the right position of the machine and where this exhaust is pointed, what if it's pointed onto the shoes of the patient and then it just blows out the coronavirus? The patient may not be positive, but it may blow the virus around your clinic, and that's not going to be sucked back into the machine or anywhere. So it's really, really difficult. Again, this is not only a virus that stays on the human body, it stays about on almost any type of surface. So how about UV lights? Do they work? What are the evidences that support this?
I haven't seen any evidence-based study. I'm sorry. So I will research and comment on that.
If I may just add something with regards to, because I understand people will, given the information we've discussed right now, once the ECQ is lifted, I would understand some clinics would still open, definitely.
Yep.
So I think it's I think it's best that they somehow know how, if ever, to deal with this thing in their own practices. So if I may just share, I don't know if this is going to be a guideline that's going to work for the time being during this COVID pandemic. But what we're planning to do is sort of a mitigation on how to go about treating patients. So right now, because of the aerosol, we've tried to divide the clinic again into two parts. So the part is where the part where we're gonna do an aerosol producing treatment. It's gonna be in a contained area. That's the first thing. It has to have a containment. Um, Mainly because we want to keep the aerosol inside to prevent the spread of the aerosol and other viruses that the patient may come in contact to other parts of the clinic, such as the reception area or the other operatories. Second is the
Okay.
evacuation of the aerosol produced. So yes, it's probably you can use the extra oral aerosol, but as an additional layer of protection, I would suggest to have a sort of exhaust ventilation in addition to the extra oral suction. So you have the extra oral suction pointed directly towards the mouth or the area where you produce the aerosol, and then an additional exhaust probably at the ceiling, so that if there will be some aerosol produced at the sides or on the area, it's going to be sucked out and then go out of the clinical area. And syempre, on top of that, standard precautions pa din. Such as disinfecting the area, cleaning the area, blood splatter, blood spills. It has to be still in place. Hindi kasi pwede na we're just considering aerosol because it's an airborne infection. Again, we have to agree that we also need to do standard precautions, and then on top of that, the transmission-based precaution. So, I
Okay.
think yun yung medyo nakakalimutan ng mga ibang dentists when they're trying to look for means of, we're gonna do practicing na in a matter of 2 to 3 weeks. What do we do about
Yeah.
this? You have to still consider standard precaution should be still in place, and then put something on top of that, which is your
Yeah.
transmission-based precautions.
Yeah. I have an experience in practicing in the mall practice, and usually malls really don't have good exhaust systems or poorly maintained exhaust systems. Sometimes their air cons are also down. So another question here that we could ask is which doesn't need an answer. I mean, is it actually ethical to just blow up this contaminated air into the general public? Is that even safe as well? So,
Definitely not.
But
Definitely.
that's what's happening on a daily basis.
you're cleaning air in your clinic, but then you're contaminating your environment. Then I mean, what good is that in terms of trying to contaminate or flatten the curve?
There is a study that says, again, what we're trying to incorporate in our practice is to get an industrial exhaust fan, and then
Yeah.
at the ceiling, install it at the ceiling, and then place tubings, pipes going out. But at the end of the pipe, there has to be a HEPA filter, so that whatever it sucks in from your clinic, once it goes out, it sort of undergoes the filters of the of whatever we put it in there. So para pag lumabas siya, it's relatively safer than nothing. So
Yeah.
but not an absolute.
And in addition to that, and in addition to that, put it this way: once you lift the ECQ, you're putting all the people out in the street anyway.
yes,
It's like saying that you've just released all the viruses that are available
that's true.
to the public once the ECQ is
That's true.
lifted. So I really don't get the point of being worried about releasing the virus. It's just as if you're just saying that the person, your patient, has just walked out of your clinic, and he'll practically be doing the same thing if he's COVID positive. It's just that for a minute, for an hour or two, he was in your clinic, and then he happened to walk out, then decided to spread his infection even farther. So it's I don't know. Although the HEPA filter is really a good suggestion, there's no denying that it's an extra layer. But then again, to worry about that, for me at least, once the ECQ is lifted, it's gonna be all over the place anyway. So,
I think what we're trying to come down to is that this coronavirus is not something like the normal kind of bacteria or normal kind of flu viruses that you can get away with just preventing or lowering the chances. But I think that we should approach it with rather an absolute solution with how, in proportion to how serious this virus is and how deadly it is actually to the human being.
And one thing I'd like to add, there's a myth going around that it disappears with heat or weather. It is not true at all. I mean, there is no proof at this point. In fact, it will survive any kind of temperature. It will survive the cold. It will survive the heat. That's another thing particular to this virus. So,
are there evidences regarding autoclave?
When summer comes, it's gonna go low. No, it won't. Autoclaves ideally are supposed to kill the virus. I mean, viruses basically, I think, with cold sterilization and all, but provided that it's done properly. Okay.
Yeah.
Well, then again, it's supposed to minimize, if not sterilize. So, again, with reservations, it should work. It should work. Autoclaves are supposed to.
Yeah.
Let me emphasize on that. But again, given the amount of information that we have on this virus, information can change. These can change. So given what we know about viruses, their autoclaves are supposed to work. They are supposed to, at least.
So far from this discussion, what we're talking about is we need a good exhaust system wholly as a clinic more than what we're producing chairside. It is a must that we must have windows and a good, basically a good exhaust system. Aerosol exhaust systems are not a guarantee just yet. There's not substantial evidence to that it really works and that it protects the whole clinic from any of these viruses. And I think, as Dr. RJ pointed out, that isolation rooms are a must in terms of these clinics. There are a lot of clinics that have 2 chairs beside each other, 3 chairs beside each other, 5, 10 chairs beside each other, which doesn't seem ideal in this kind of situation where not only social distancing must be practiced, but also the aerosol, everything that's going around it with that patient should also be done. So another question is, how do we clean the operating system? I mean, the operatory. How do we go about that? Dr. RJ, how do you disinfect the area? How does your staff disinfect the area?
Actually, again, let me reiterate. It's the same thing. Standard precautions would tell us to use the same disinfectants, the same cleaning materials that we use, even if there was no COVID. I think we have to just be more conscious about it. Every patient, whether you did any procedure to that patient or whether it's just consult or aerosol producing procedures, you still have to follow the same protocols released by those guidelines way back before COVID was even existent. So I think kung ano na yung mga ginagamit nila, as long as it follows the guidelines, you can use that.
All right. So mistings are not necessary.
Which one?
Misting.
Misting.
It's like you put in a fog of bleach.
Well, we actually do misting in the clinic.
DOH refuted this. They said that it doesn't work, but then they retracted their statement and it said that it doesn't work on living organisms, but it works on non-living organisms. So what's the bottom line?
I think it's just another layer of protection. Again, we try to minimize the amount of virus. We cannot 100% make sure that it's completely eradicated. So if there are means of lowering it to a certain extent na hindi na siya magiging transmissible, then why not? We do misting in the clinic. It helps. We use it Saturdays, I think. And then we mist the whole clinic at least twice a month. You get away with wall-to-wall cleaning because if you get if any bacteria, viruses get in contact with the mist, it technically kills it. With the UV, I've attended an infection control seminar way back. I think St. Luke's uses the industrial UV light to disinfect their ORs. And I think we might be getting one too, to again just put another layer of protection. If we can reduce it to a certain degree where it's almost as if it's not transmissible, then why not? We can try that. again, we don't know much about these things, and we can only try to protect ourselves and minimize the risk of transmission. And if that means we use additional UV or additional misting, then why not? Diba?
And UV lights that are actually coming from reputable companies. A keyword here is industrial, as you said, and there must be a lot of testing, a lot of proof that must have been done before actually using that, rather than just buying it off the counter or off an agent and say that, hey, this will work. It's also hard to say because we don't know what's happening in the micro world.
And also, let me just add, for those interested with UV, there's also a safety issue with UV. Remember that is UV light that is harmful to your eyes. So there has to be a certain amount of time that it's on. So if you're gonna be inside the clinic or the operatory while the UV light is on, that could destroy your eyes. So you have to understand some things have safety issues before you try to use it and utilize it or include it in your existing protocols.
Yeah, and make sure to read the manufacturer's instructions on that.
Yeah. For the UV light, may I add to this? Yes, it will disinfect the clinic if there's no one around. So any leftover virus, for example, probably will get killed. I mean, at this point, there are no guarantees, of course, but we're basing it on previous knowledge that we have, not on just how this particular virus behaves. But then again, I would like to reiterate the fact that once a COVID positive patient comes in contact with you, the UV light doesn't have any use, because of course you cannot turn it on when a patient is inside your operatory. So that's one thing you have to consider. Then last, like what RJ said, it's adding layers of extra protection, but you have to consider the when as well.
Yeah.
And what are we worried about? Patients coming in COVID positive and getting treated.
So we have a question here from Dr. Joy Talaid Bonsol. And basically the question is revolving around what we're discussing right now, but just to add on to it, how about the waiting areas, the waiting areas, the office, after each day, everything has to be disinfected, or it's just the operatory?
Well, if you ask me, what we do in the clinic is we do every patient. Well, depends. We try to categorize areas where we know will be at risk of having the virus after each patient. So, for example, with the operatories, it needs to be cleaned every patient. For the reception area or the waiting area, it might be best to clean it at the start of the day, at the middle of the day, and after closing. So it depends whether the area is high risk or low risk. I think there also has to be an assessment on the spaces that you have in your clinic. Designate areas wherein this is going to be an area with minimum risk. So let's set a protocol for this. This area will be high risk. So there's a need to put more layers of protection for this, cleaning, decontamination, sterilization. It's not going to be just a one protocol for the whole thing, because again, it's not going to be efficient, and it's not going to be a repeatable thing if you consider all areas are going to be at a higher risk. So
I think for the waiting areas, this is a place where you have to practice social distancing at the very least, to limit the number of individuals in the waiting area. The same way you would limit the number of individuals, for example, in a grocery store or in a drugstore. It should be the same, that there is space between these patients who are waiting, that you have at least 3 feet between them. Because even then, even if it's an enclosed space, as long as there's no treatment going on, then at least we can assure the patient that they are there with minimum amount of contamination and infection.
I think that is what answers doing the telephone consultation, because you keep the amount of people in that waiting area at the minimum. Because if you're gonna tell the patient, "Oh, come in at exactly 9:00," and then you don't appoint any other patient until 9:45 or 10:00, so it limits the amount of people inside the waiting area. Also, if you do triaging, ang bilis nung turnaround. So if you don't need to, if you will not do anything to that patient, for example, just purely consult and then give treatment plan or antibiotics, ask them to go home immediately. They don't have to wait there, because the more waiting time, the more exposure they'll have.
All right. So, as how the government establishes social distancing, it should be the same thing that we do within the clinics. And I think we don't even have to overthink this, because even in grocery stores, exactly as Dr. Jet said, even in drugstores, even along the queues, there are limited people who can go in. There is also a line outside to which people are not sitting beside each other, but they're sitting apart from each other. So these things should also be practiced in this new norm that we are facing. So this personal space that we usually had for like about a foot around us, it's now about 6. I think there are a lot of researchers that you need about 6 feet radius around you that would protect you in this new norm of social distancing. And okay, we're almost finished with the protocols as far as the clinic is concerned. One question: is there any prophylactic medications right now that we could give to the patient or to ourselves before we head into this? Can we drink a high dose of vitamins before we dive into the fire?
None.
None.
Right. I'm sorry to say, but this is a different kind of virus. No, again, I will go back to the fact that even healthy individuals do get infected, and some of them actually die from it. So there's really no assurance. Yes, of course, you can. In fact, the thing on vitamin C is even questionable, because there are researchers going out there, even 2 years, 3 years before, that show that there is no truth to zinc and vitamin C improving your immune system. We have to bear that in mind. And even with the heightened immune system, you still can get infected. So the best way is to avoid contamination as much as possible, infection as much as possible. And that's it.
I guess it's another layer of protection again, but not a guarantee, as like any kind of solution that we have. Yeah.
I mean, you've had patients who were athletic even and ended up dead. So.
Okay, so I think we're. I'm trying to think if there's any stone that we haven't unturned.
If I may just add, we're doing what we call health tracker for our staff. I think that's again another important layer of protection for the staff and the patients.
Yeah.
So what we normally do is record our temperature twice a day, one in the morning and one in the afternoon, and then let the health tracker know if we're experiencing any COVID symptoms. This is actually very helpful, because it sort of gives us an idea and a way of tracing whether a staff could be infected, or whether the patient could have been infected by the staff. So I think that's one another thing that all practices should start doing. Assign a person to do the health tracking, take the temperature, and then ask them if they're experiencing any types of COVID symptoms. And if they do, they should report it and then go on an isolation or a quarantine for a period of time. Also, I think this is very important. That's why it's safe to create specific duties per day for dentists. Because if, for example, on Monday you'll be doing this patient, and a few days later the patient develops symptoms, it's easier to track which staff, for example, assistant and dentist, that have been exposed from this patient. So even without the symptoms, if the patient turned out to be a positive COVID patient, you ask the dentist and the assistant to take quarantine or isolation for 14 days immediately. So I think that's another thing that we should be incorporating in our protocols right now.
Mm-hmm. Okay, so we're so let me just finish a few questions here. which we pretty much discussed. Just let me give attention to these questions. One question is, how long will you turn on the UV light to say that the area is sterilized? I think that, as Dr. RJ mentioned a while ago, that it's according to the manufacturer's recommendations. We have to read the manufacturer's recommendations on how long it should be. It differs per unit, and it differs as to the proof of actually these lights work. And here's another, how about the water supply from the chair? Is there any need to, do we use UV water? Do we use distilled water? No, it's the mouth that is actually contaminated.
Actually,
it's
there's
not
a
the water.
controversy.
There's no need.
Yeah, there's a controversy on Twitter between epidemiologists and scientists about the use of pre-rinse gargles. One scientist would say that if you have to do the rinse, you might as well ask the patient to do a rinse every breath, every take in and take out of breath, because the virus is in the lungs, remember. So technically it's not in the mouth. It comes from the lungs. So every time the patient breathes out, there's going to be virus. So regardless of doing the rinse, I think every time the patient breathes in and breathes out, there's going to be some sort of virus that's going to be in the air. So I think it's just a psychological thing to do the pre-rinse, but there's no harm in doing the pre-rinse. But I think the point of the question is whether they could add an antiseptic to the water lines of the dental chair. Again, if it's gonna be just in the mouth, the antiseptic is not going, or the antiseptic is not going into the lungs. It's basically useless. I would just go with distilled water.
Again, I'd like to reiterate the fact when it comes to the pathophysiology of this virus and how it gets introduced to the body, it's through aerosols. It doesn't have to do, and where does it come from? As Dr. RG said, it comes from the lungs. It comes from probably the salivary gland. So no matter how much you rinse the oral cavity with whatever disinfectant you want, any antiviral, antibacterial method that you have in mind, it will not change the fact that the point of origin of this virus is not in the mouth. The mouth is the entry point to the respiratory tract, and that's why we are put at very high risk. But other than that, the origin comes from the respiratory tract, and in some cases, even the salivary gland, which both the entry point is still the mouth, no matter how you put it. And then you also have, of course, coming from the nose, which we still get in contact with, because this is the area which we work with. So that you have to bear in mind. It doesn't have anything to do with whether or not you have any of the microbes in your mouth. The mouth is not the main issue here. It's the mouth being the entry point of the bigger problem, which is the respiratory tract.
Yeah. So we can only add additional layers of protection, but again, because of this way of how it happens, how you get infected, it's really hard to prevent, because this is something that we normally do in order to live. So it's just a matter of living. You can get a chance of being infected. You don't even have to work or expose yourself. You just have to live, and you have a high chance to get infected. So that's how bad this is. There's a very good comment by Dr. Joy Felizardo Villacorta. Is it possible for us to wash with soap or disinfect your impression materials trays before sending to the laboratory? It's an interesting standpoint, because what her sentiments is to protect also the dental technicians, who are another endpoint of this possible virus within the test. So everybody around the dental profession, I think more than what we are trying to do, in terms of protecting ourselves, is that we should also think about our social responsibility towards our surrounding, towards our household, towards our family, towards our community, towards our country, towards our city. is that we since we are the highest possible chances to be a vehicle to infect or to transfer this virus, we have this very heavy social responsibility to protect everyone around us and not only ourselves. So I think we have covered everything. I'm gonna give. Would you like to add anything before I allow you to give your last lines or the question? I mean, the answer to what then should our personal prerogative in the name of science, in the name of protecting our lives as human beings, more than just being dentists as part of a community, what should be our prerogative as we go back into the after this quarantine? What's the bottom line?
I think at the end of the day, siguro we have to, yes, consider that we have a moral responsibility to answer for the patient's call, to treat them if they're having anything, complaints or whatever. But also, on that same note, we have the moral responsibility to prevent the further spread of this virus. Because, again, there is very little that we know of what's going to happen in the days or months to come. And it's better to prevent it from spreading rather than you yourself will be the cause of the spread. As much as there are a lot of guidelines telling us to do this and that, right now it's all interim. Again, it may change. And as much as we want to protect each other, if one dentist in a certain area would practice the same way before COVID happened, it's gonna change everything then. So I think you have to weigh in on the risks for us dentists and for our patients. So also siguro take into consideration the finances, but is it really worth it? Yun lang yung magiging question natin. Is it really worth it?
Yeah. To substantiate the bottom line, I mean, it's very strong statement, very strong bottom line from Dr. RJ. But the interesting thing that I want to take out of what Dr. RJ said is that we have a moral responsibility, and this is not only an individual responsibility, but it's also responsibility of the organizations, the educating institutions, the associations that revolves around dentistry in terms of educating the public, educating the dentists. I see more TikTok videos on the internet, unfortunately, rather than on the information that we need to undertake as professionals in this pandemic. So I think we all have a responsibility of increasing. I mean, we all have this moral responsibility to human beings and as human beings in this pandemic. Thank you for that, Dr. RJ. We wish you, we pray for your safety in the front lines. We know that on Monday you're going to go back there into the fire.
Yes.
Consider all the possible protection that you can have for yourself. Thank you for giving your input. It's very valuable to everybody who attended this webinar. And Dr. Jet, may we know your bottom line?
My bottom line. Okay, a lot. First of all, I don't want to really paint a dire picture, but we have to face the reality. This is uncharted territory we're dealing with. We haven't seen this kind of virus in years. I mean, this has been the top on the list in terms of SARS, in terms of MERS, even Ebola. It's something that has yet to be controlled. And the thing that I fear the most is that if and when the ECQ is lifted, the people will think that life will be back to how it was prior to COVID. And I'm sorry to say, but from a scientific viewpoint, this will never be the case. There will be changes. One of them would be social distancing. And that we have to bear in mind as we go back into our practice. As what Dr. RJ and what you have mentioned, we have the moral responsibility to make sure not only to protect ourselves and the ones around us whom we love and treasure, but we also have the responsibility towards society to make sure that this thing doesn't spread any further. And at this point, there are no assurances. And I do understand the economic impact on all of us dentists that we highly rely on our profession to earn. But if there is a way to go about this without having to really put people at risk, then I think that this should also be part of our prerogative. At this point, sorry to say that things cannot go back to normal, even post-quarantine, especially for us. I mean, for probably other businesses, yes, because there will be things that can be put in place that will ensure the safety of the public. But for us who are directly in contact with people, and because of the nature of our profession, I think we should think twice and we should think hard before we start going back into what we think is normal. There isn't any cure at this point. There isn't any vaccine available at this point. There are no prophylactic measures that can be taken. And even the things that are in place, the recommendations that are in place are not enough to serve as a 100% foolproof guarantee, not even 80%. The moment you step into your operatory, you already put yourself at risk. And if you are willing to do that, then by all means. But take note of the fact that, you know, it's a gamble at this point. It's really a gamble. And if the gamble is worth it, go ahead. Not to say that, you know, we stop treating patients, because we also have the moral responsibility to treat those who are in dire need. And if it's not life-threatening, if things can be put on hold, well, if you think it's worth, if it's not worth the risk, then by all means. But you know, it's something that at this point has no answer. It has no end. We don't even know if we've already reached the peak. And even if they say that we've managed to flatten the curve, it doesn't mean that it's not there anymore. It's just flattening the curve simply means that, you know, we can accommodate hospitalization, we can accommodate people for treatment. And we're buying people time until such a solution comes out. But until then, there are cases of reinfections. There are countries who have flattened the curve and who are now experiencing a second wave. We have to put all of these into consideration.
Mm-hmm. Okay, so very interesting standpoint. Again, thank you, Dr. Zet, for these inputs. I think the main takeaways that we all can get from this webinar is that from Ma'am Zet's side, she recommends that we do absolutely nothing, absolutely no treatment, because there is basically this virus is unknown until this point, even with the evidence that's available. It's ever changing, and the best way that we can protect ourselves is, fortunately, stop working or abstaining from working. And Dr. RJ is his take here is that if you have no choice and you really have to jump into it and you have to serve your function, his point is that you can add as much layers as you could, from the triaging, from the teledentistry, from the triaging, to the what you can wear, to how you can treat your clinic, how you exit your patients, and how you dismiss them. But you can only add to the layers, but still up to this date, there's no absolute solution or protection that we can do to protect our lives and the lives around us, including our families. And going back to Ma'am Zet, what she said is that the best time for us to start this again, to perhaps go into a little bit of the previous normal, is we have to really wait for a vaccine, which will be available, according to research, it's about a year or so before this actually comes out. So I think one of the bottom lines we can come up here is that protect yourself at all times, number one, and number two, wait for a vaccine. Would you agree with that?
Yourselves.
I think that's if you really want a 100% solution, that would be it. Other than that, it's going back into practice, but knowing that you are at risk. You are at risk. There's no saying, you know, you won't be or it won't affect. No, I'm sorry, that's a fairy tale. If you're going to think that, you know, you can go back into practice and not get sick, I mean, there will always be that risk, and it's high risk even. It's not just, it's high risk, and that you have to bear in mind.
Mm-hmm. Okay. So, doctors, thank you for being and helping the general public as far as who we have live right now. Those of you who are watching this, thank you for tuning in. We had a good retention of audience for 3 hours. Basically, we trimmed that 3 hours down to 3 minutes in the last part. But it was worth the discussion. Now, there are a lot of questions here that are being asked. We talk about it in some segments previously, but there's really not enough time to talk about everything. So there's a lot of things that are going around with this virus. And what we know right now, what we're talking about right now is only what is available as of April 17, as of yesterday. And that's what we can only talk about. What we should know about in the future is our own personal, professional responsibility to educate ourselves. There is no shortage of information on the internet. You can find everything on the internet. You can, in one of our posts, if you check here on our page in the Biomechanical Institute for Orthodontics, is that you're going to see an infographic, and it's basically we place there there's a lot of reference there that you can click easily. There's some social media toolkits. There's some posters that you can get from those links. The triaging. There's also some virus information, new measures on how to do it. Dr. RJ recommends the dentist. What was that again, Dr. RJ? General dentist, something from UK.
Yeah, the GDC guidelines. Yeah.
Okay, the GDC guidelines from UK and also from the Scottish Dental Association. Dr. Jet recommends that we do some readings on from Nature and what again, ma'am, was that other reference that you had?
Peer-reviewed journals, yeah.
Yes, peer-reviewed
yeah,
journals.
peer-reviewed journals.
The peer-reviewed journals, you have Science, you have Nature, PNAS, the procedure for something sciences, pnas.org.
Yeah.
They have the latest on, and these are all scientists working on the COVID. So if you want to get material on how COVID works, the latest findings, the DNA sequence, the protein, whatever, it's all there on the peer-reviewed journal.
Okay. So again, dentists, please don't rely only on news outlets to inform us on this situation. They will inform us on the statistics, and I think that's as far as they could bring us. But as far as we could bring ourselves into our own practice, there's no other person that we can rely on how we're going to go about in this new normal. But I think we can only rely on ourselves, on our own practice. When we're sitting in between when we're sitting beside the patient, there's only the PPEs and maybe your glass box that separates you from the patient. Nobody's going to be there to protect you, so you have to fill yourself with knowledge before you jump into it. There's no shortage of this information on the internet. WHO, CDC as well are good references for whatever you need. So with that, we thank you everyone for tuning in. This link will be available for the next few days if you want to replay it, if you want to go back to some parts of it. Yeah, you can go ahead and replay that. So thank you again for tuning in. Thank you again, our panelists, Dr. RJ Dulay and Dr. Jet Po, for your very valuable expertise and experiences on this virus. It was a pleasure having you. And also, again, we want to thank you, Dr. Amy De Jesus, who came up with this idea, and also AADS and also Dental Access, who basically came up with this idea. And basically, that's